Good morning, everyone. Now, today I am going to talk about ECG for anesthesiologist. Nowadays, when you are working in institution, and many times ECG, echo, all these investigations are already done on a patient. But most of the time, what I have seen is that whenever echo report is available, we hardly look at the ECG. In fact, we overlook towards the ECG. But this, I feel, is not right, because our conventional teaching is that what ECG can teach us is rate, rhythm, arrhythmia, chamber enlargement, presence of ischemic heart disease, and electrolytes. But beyond that, ECG teaches so many things about the heart. And if you are a good ECG reader, or if you are good at ECG, you can find out so many different things or so much of information from ECG. For example, it can give us information about volume overload over the heart. It can give us information about pressure overload over the heart. It can give us information about ejection fraction. It can give us information about pulmonary hypertension. It can give us information about LV aneurysm. It can give us about, to some extent, which type of congenital heart disease. And it can give us information about which coronary probably is blocked. This is a lot of information ECG can give us whenever such kind of, if you are well versed with reading the ECG. So my aim of presentation, we are not a physician or we are not a cardiologist. We don't want to diagnose very minor things or things very precisely through ECG. And if I say that I'm in next 20 minutes, I'm going to teach you that Leo Shamrock or PJ Mehta books, then it is practically not possible. My aim is to just make you aware of how to identify high-risk patient as far as ECG is concerned. Can we predict some perioperative event with the present knowledge of ECG as an anesthesiologist? And can we manage complication, or do ECG give us some kind of clue when you are in a difficult situations? And I will stick to this. So rather than teaching ECG, or rather of each condition, I thought, why not to share my clinical cases or my experience about ECG over the last 10 years. So 1 ounce of practice is worth than 1,000 pounds of theory, and I'm going to share with you few interesting cases as far as ECG is concerned. Now, this is 35-year-old female posted for a simple MRM surgery, and when one of my colleagues saw the ECG of this patient, she postponed this case because there is increased PR interval, there is interventricular conduction delay, there is increased QT interval. Overall, all there is, obviously it is looking like that there is increase or there is a conduction problem to the ECG. But very important fact that she overlooked is the speed of ECG with which that ECG is taken. Normally ECG should be taken on a 25 millimeter per second speed. This is taken with double the speed, and that is why all intervals are increased. This is a normal ECG. When we took the ECG on this normal speed, this was absolutely normal ECG. So whenever you look at the ECG, the first thing that you must look is whether the speed is proper and whether the calibration is proper. When these two things are proper, then only you should be able to comment, or you should comment on the ECG. That is very, very important. Another case, 5-year female posted for mastectomy. Patient was giving a history of syncopal attack, and when we clinically examined this child, her heart rate was 40 beats per minute. And to evaluate her further, we took a 12-lead ECG. And what is there? There was no correlation between P wave and QRS. This is a congenital complete heart block. So instead of going for a mastectomy surgery, patient was first posted for a permanent pacemaker, and then patient posted for this surgery. So this is the importance of ECG. And once you clinically evaluate the patient, and if you took the ECG, it gives us a lot of information. As far as block is concerned, from first MBBS, we are hearing all this, that is first degree heart block when there is a PR interval is prolonged. Here, conduction at AV node is getting delayed. While in second degree heart block, there are two types. One is Wenke batch, means conduction is getting delayed with each beat and there is a dropout. And in second degree type 2 block, there is sudden dropout without increase in conduction delay. Now, I would like to ask you, which one is more dangerous out of these two? So the second kind of variety, that is Mobitz type 2, is more dangerous. Why? Because in first one, there is AV node is like it is getting tired with each beat of the heart, and every time it is delaying the PR interval, and there is suddenly drop of QRS, AV node get regenerated, and then immediately next beat comes. So on the contrary, in second degree, when there is a second degree IV block, it is an infranodal block. These patients can land into permanent complete heart block at any point of time. That is why second degree heart blocks are much more dangerous, or 2 and 1 block, more dangerous. Third degree heart block is complete heart block. That is again more dangerous. This, what I was talking about, second degree IV block is infranodal. Just below the node, there can be a block, and that is why it is more dangerous. Two interesting cases. One more or less patient's profile was same. One is 40-year male, another is 45-year male, but both are giving history of intermittent palpitation. First patient's heartbeat was 80, but regularly irregular. In second patient's heart rate was 80, but it is irregularly irregular. Now, other investigations were within normal limit. When we saw the ECG of both patients, in first patient, there were ectopics, but see the morphology of ectopic. And in second patients, also there were ventricular ectopic, but see the morphology of ectopic in second patient. This is a monomorphic ventricular ectopic. Ectopic of same configuration, which can be a normal phenomena. This can be present in normal patient. But this is a polymorphic ventricular ectopic. Ectopic are occurring in solvos. They are occurring in tandem manner. So these are the more dangerous patients. Now, when such patients comes for anesthesia, as an anesthesiologist, what we should do? Ask patient to take a brisk walk for 6 minutes, 3 minutes. Once you increase his or her heart rate, and if ectopic disappears, this is a good sign. This can be a normal phenomena, and surgery can be done uneventfully. But if at all ectopic increase, this is a dangerous sign. This patient needs further cardiac evaluation. Such kind of simple evaluation we may need during the perioperative period when you face a patient with ectopic during PAC or preoperative evaluation. So our aim is to identify potentially dangerous arrhythmia like high degree AV block or multicular ectopics or extreme tachy or bradycardia. Now, this is a very common question asked in exam or day-to-day life. When to treat ventricular ectopic? Whenever they are associated with hemodynamic changes, whenever ventricular ectopics are occurring and patient is complaining of sweating, breathlessness, chest pain, when they are occurring with couplets, bigeminy, trigeminy, when they are multifocal like this, means each topic is of different configuration. When their frequency is very high, more than 10, more than 15, or when there is a R on T phenomena. What do you mean by R on T phenomena? R is the depolarization, while T is the repolarization. During the next subsequent repolarization, if suddenly depolarization occurring, it can elicit a ventricular tachycardia. And if this is happening on an ECG, you must treat it immediately. Now, this is again a very interesting case. 30-year-old female posted for emergency seizure. Patient was giving a history of intermittent palpitation and giddiness. There were no other comorbidity. All lab was within normal limit. Echo was not done because it was an emergency. But when I saw the ECG of this patient, what ECG is showing? There is a short PR interval and there is a notch on the R wave, which what we call it as a delta wave. This is a classical pattern. What is Wolff-Parkinson-White syndrome? What does it indicate? It indicates there is a presence of accessory pathway apart from AV node. There is a presence of accessory pathway through which atrial impulse will be conducted towards ventricles. And when this is present, this patient is likely to produce SVT kind of picture during a perioperative period. And in this patient also, we arranged a defibrillator inside the OT, then we have given a spinal. But after patient pitocin, patient have a symptomatic episode of SVT, which is easily reverted with presence with a defibrillator. In these patients, if you give anything that blocks the AV node, like verapamil or beta blockers, it will aggravate this kind of arrhythmia because conduction will occur more through an accessory pathway. So the cardioversion probably is the best treatment when there is a WPW syndrome is there. Now, this is a 70-year male bedridden patient from 8 to 10 days and now posted for tibia plating and spinal given. Our orthopedics friends are very much keen in cleaning the patient's limb, so they took adequate time, maybe half an hour, to clean his lower limb. And by that time, patients suddenly become unstable during this procedure. We took his 12-lead ECG, and what we find? We find that these changes were not there in his previous ECG. There was a deep S wave, there was a Q wave, and there was a T inversion. It is a dislodgement of the embolus into the pulmonary circulation, and that leads to a pulmonary embolism. Immediately, rather than going ahead with the surgery, we postpone the surgery and put him on anticoagulants. Now, this 65-year-old female posted for lap cholecystectomy. Patient is a known case of hypertension, diabetes since 10 years. Echo lab was normal. Intraoperatively, patient suffered with a sudden increase in heart rate up to 160 beat with irregular rhythm. When we took the ECG of the patient, what was this? This is simple atrial fibrillation. How atrial fibrillation is to be identified? Change in RR with unsteady baseline is the classical feature of atrial fibrillation. Change in RR interval with unsteady baseline is the classical feature of atrial fibrillation. Now, can you predict this atrial fibrillation occur in a patient from pre-op ECG? Yes, many times you can predict. How you can predict it? You have to look at the P wave, morphology of the P wave. If the P wave is bifid, P wave is more than 3 small squares, it means that LA size is more. P wave has to be seen in second and V1 lead. In V1 lead, it will appear like a biphasic P wave. And it has been proven that when such kind of morphology present, or when LA is enlarged, 50% of these patients will have atrial fibrillation during a perioperative fight. Even echo-wise, if LA size is more than 40 millimeters, then every second patient there will be a chance of atrial fibrillation during the perioperative period. So if you can predict this preoperatively, then you can take adequate care. You will avoid the irritability of the heart by avoiding this electrolyte. You will maintain the electrolyte balance. You will avoid all those conditions that will aggravate such kinds of arrhythmia. So this is very, very important that you should able to predict such things in your preoperative assessment. Now, this is again a very interesting case. 60-year-old female, known case of hypertension and diabetes since 20 years, posted for lap cholecystectomy. We are unable to judge her effort tolerance as patient was having severe osteoarthritis with bilateral edema of feet. Lab was within normal limit. Echo was within normal limit. But when I saw the ECG of this patient, there is no R wave present in V1 to V6. This is usually an indication of poor LV function. Not only that, there is non-settling of STT changes without the presence of unstable angina or a chest pain. In a normal stable patient, it indicates the presence of dyskinetic LV. So I requested surgeon not to go ahead with surgery and repeat the echo. And we repeated the echo, and what we got? There is anterior dyskinesia and septolateral akinesia with 30% EF. And there was some mistake due to the similar names, and echo report was SAP. So it is the importance of ECG. Looking at ECG is very, very important. This dyskinesia, hypokinesia means wall is contracting less. Akinesia means not contracting at all. And dyskinesia means when LV is contracting, that wall is contracting outward. These are the more dangerous patients. There is a thinning of LV. Under stress, this can even rupture, or there is formation of clot in this segment. So it can be seen with ECG of non-settling ST segment in a normal stable patient. This indicates that there can be a presence of dyskinesia on the ECG. Now, great or the important limitation of any ECG finding is it cannot diagnose the ischemic heart disease with that much sensitivity and specificity. There is one interesting paper which says that only 50% of the time that ECG will able to pick up the ischemic heart disease, because when heart is at rest, patient may not suffer with hypokinesia, akinesia, or there will not be any changes on ECG when heart is at rest, and that is a very big deficiency of ECG as a monitoring tool. Now, all of you know that whenever there are changes in either 2-3 AVF, we call it as an inferior wall. When it is V2, V3, V4, we call anteroseptal. It is in one lead, and V5, V6, we call it as a lateral wall. Coronary anatomy is also like this. When there is a right coronary involved, changes we will get in 2-3 AVF. When LAD is involved, we get changes in this area, while in circumflex we will get changes in 1 in AVL. But for this, you must know, or you should be able to correlate with the anatomy of the coronaries. Suppose there is a proximal LAD is blocked, so whole of the LV is at jeopardy, and you will get changes in the whole of the V1 to V6. There will be STT changes or T wave inversion. Similarly, you can predict the presence of coronary block, or can suspect presence of coronary artery disease as per the ECG changes. Now, how to remember this? Now, what is ECG basically? Basically, ECG, we are looking at a heart with different angles. Maybe from inferiorly, maybe from foot we are looking at the heart, maybe from left side we are looking at the heart, and we are collecting electrical activity of heart from that angle, and we are trying to present it in a tabular form, in that form towards you, and you have to analyze. For example, if you are looking at this building from left eye, this will be visible like this. But when you close left eye and when you look at the building from only right eye, this building will look like this. Similarly, you are looking at a heart in a different plane, in a different angle. When your 1, 2, 3 and AVR, AVL, AVF, for these 6 leads, you are looking at a heart in a coronal plane. While in limb leads, that is V1 to V6, you are looking at a heart in an axial plane. Once you understand this, and once you try to correlate this with your ECG findings, you can diagnose so many things on ECG. So this is, I think, a very, very important slide for anyone to remember. Now, T-wave inversion. This is a 20-year-old female posted for simple D and C. When I saw the ECG of this patient, there is a T inversion in V2, V3. But otherwise, all ECG was normal. There was excellent effort tolerance, no other symptoms. This is a normal finding. Presence of T inversion V2, V3 in a young female, what we call it as juvenile pattern of ECG. Even in pediatric patient, this can be present. When patient is asymptomatic, young age, you should not give too much importance for such kind of T inversion. We can have ECG changes even without the involvement of the heart. For example, this is 30-year female with road traffic accident posted for decompression craniotomy, and you can see a giant T wave inversion. This is not a IHD or ischemic heart disease. It is the raised intracranial tension that is causing a giant T wave inversion. And in this patient, there was an intracranial hemorrhage, and with a shift occurring in the cerebrum, and that has led to changes in ECG. So giant T wave inversion can be indicate CNS cause or other causes like acute coronary syndrome. It's a very interesting case. 50-year-old diabetes since 20 years admitted in surgical unit for pain in abdomen and vomiting, and patient was posted for gastroscopy. Actually, I was there to attend one ERCP call, which was after this gastroscopy. And I was just sitting casually. I saw the paper of this patient or ECG of this patient. And to my surprise, ECG was like this. There was gross STT changes in all the leads with ST elevation in AVR. I suggested that gastroenterologist not to touch this patient because this can be a coronary event. And as we are a very good friend, he immediately postponed this patient and he called cardiologist. He involved the cardiologist. When cardiologist see this ECG of the patient, he posted this patient immediately to the cath lab. And what was the picture in cath lab? There was a left main block, complete obstruction of left main, which is patient was giving a history, was presenting with pain in abdomen and vomiting. And to our surprise, with after first shoot in cath lab, patient arrested and we could not revive the patients. Such was the coronary block. Suppose this gastroscopy would have done in this patient, it was a sure shot mortality. So this is the importance of ECG to pick up the things at earliest. Now, 60-year-old female posted for total knee replacement. Patient was giving a history of giddiness and blackout, diabetes since 10 years, hypertension since 15 years. When I saw the ECG of this patient, what it shows? There is a presence of RBBB with left axis deviation. What does it mean? It means presence of bifascicular block. Means already our right bundle branch block is there. Plus there is anterior fascicle is also blocked. These are the dangerous patients. Dangerous patient in that sense that these patients cannot be done at nursing home level. You can do this at institution level where pacing facilities are available. If suppose suddenly this patient land into a complete heart block, what you can do? You cannot do anything if you are doing this case at nursing home level, or you should post these patients where such kinds of facility are. Such is the importance of pre-op evaluation and picking the things properly on a ECG. This is slightly out of my presentation, but this is a very interesting meta-analysis published in December 2023 in Indian Journal of Anesthesia. What they say that during intraoperative period, if there is an episode of LBBB or RBBB, LBBB is always indicates the presence of ischemic heart disease, but they say that if there are no hemodynamic consequences, you should continue with the surgery and you should monitor this patient in a perioperative period. Only 2-3 days back, I have just read this, and that is why I just add these 2 slides in my presentation. This is very interesting meta-analysis. If you want to read, it is available on net. Now, this is last case. 50-year male posted for lap fundoplication. No other comorbidity except acid peptic BC. But his wife narrated that he drinks alcohol and usually falls down. When I inquired patient, he says that he feels intermittently giddiness. Even though he consumes very less amount of alcohol, still he falls down many times. And even without alcohol, there is a history of giddiness. All lab was normal, within normal limit. But when I saw the ECG of these patients, what it indicates? This is a very dangerous disease that it indicates. It indicates a Brugada syndrome. Brugada syndrome is nothing but it is a sudden death syndrome, also known as. There is a sodium channelopathy, and ECG is very classical. There is 3 types of ECG you commonly get in blood. Code ST segment in V2, V3, V6, or this kind of ST segment in this type 2 or type 3. And these are the very polymorphic VT is very common. Heart is very irritable in such kind of patient. At least you should mentally prepare to face this situation, and then only you can manage these cases during the perioperative period. So 12-lead ECG preoperatively must be seen by anesthetist or anybody who want to give anesthesia, and that is very important. So a clever person solves a problem, but a wise person always avoids it. So good anesthesiologist may be able to successfully treat the complication, but excellent anesthesiologists do not allow it to occur. Thank you very much.